So we have to think of caries as a medical issue, not as a dental issue. That's the point, and that's the bottom line that you're going to see. The crisis we're going to face if we don't control the change in diets in developing countries, or at least learn better ways to manage the disease. In the US, caries was called the silent epidemic, the most prevalent disease in children. This was 10 years ago by the Surgeon General. Recently, the Academy of Pediatrics did a follow-up to this report, and they found we haven't made much progress since the call to action 10 years ago. We still have a lot of work to do. It's still the most prevalent disease. It's growing in severity and in prevalence in preschoolers. It's the only segment of the population where it's growing. And unfortunately, because we still haven't gotten the word out that A, it's preventable, and B, that it's serious, and for a segment of the population that's underserved, it may be life-threatening, and it's certainly highly morbid. So our work at our Center for Pediatric Dentistry that I'm going to discuss today, and why we developed this Center for Pediatric Dentistry as a partnership between UW and Seattle Children's, is to look for ways to treat children locally and develop solutions, because it is an opportunity given the fact that we're dealing with a disease which is similar in manifestation here, in fact worse than in developing countries. We have the chance to actually study it here. We don't have to go to Africa to study it. We can study it here and think about access issues. We can think about all the behavioral, social aspects of behavioral disease or lack of certain behaviors. We can study that here and then present those findings and make a difference elsewhere. And that's our goal with our connection in a nutshell with the global health side of things. We're starting to look at treating this disease, dental caries. That's the global health issue, treating the disease, treating it like an infectious disease, not waiting for a hole to form, but managing it, preventing it from manifesting the hole in the tooth. We understand it, and now we have some new technology that might allow us to do it. I did go to Peru a couple years ago, thanks to Ana Lucia Seminario, one of our 2 Peruvian faculty. And at the time, I was the only American in our faculty. I love that. Speaking of global health, I was the only pediatric dentistry until a year ago when I just hired somebody else. I was the only American. So that's pretty global, right? And we went down there, and the first lady took us to the high altitude regions of the Andes, where these kids had been screened several years before when they had complex carbohydrates in their diets. And the caries rates were really low. And then I went there, and we looked at, I don't know, several dozen kids. We were just sort of superficially looking. We weren't doing anything formal. So this is the first or second child I saw. I think even a non-dentist can appreciate this is probably about an 8-year-old. Those are the permanent first molars in the back, and they have these large soft tissue lesions called chronic hypoplastic pulpitis, or pulp polyps, that only occur with chronic disease, usually primary teeth. So this kid had a lot of cavities, and we saw a lot of kids. These kids had never seen a dentist. They don't have toothbrushes, nothing. But what's interesting, the First Lady has developed an immunization plan for these kids who don't even have rooms or plumbed water or cooking utensils, but they get their immunizations at a higher rate than some developed countries in the Andes. So I thought, well, she has access. If she has access, I might have an easier time preventing early childhood caries in the Andes of Peru than in Seattle, Washington. So we're actually going to look into how we can manage that. It proves the point that it's about access to care and early intervention, interfacing with our medical colleagues. If we keep waiting for the cavities to form, the kids in China or Peru or the Andes will never have a chance to see a dentist, or in Africa or many places around the world. We're never going to have a chance to have drill and fill dentistry. It won't happen. We can't drill and fill our way out of the problem. We have to figure out some other interventions that are before the disease manifests itself as a cavity. We have really 2 diseases in dentistry, caries and periodontal disease. We've got oral cancer and a bunch of other things, but most of dental disease is in these 2 categories. It's about 85% of dental disease. And they have a couple of things in common. There's an infection that's responsible for both. There's a biofilm that's responsible. And some patients have refractory response to this. No matter how well they clean their teeth, they're going to have a problem. But the difference is, in the case of periodontal disease, if you've ever had gum disease or bone disease, or you know somebody who's had it, the host response is actually the cause of the disease, an exaggerated immune system response to the Porphyromonas gingivalis bacterium. The bacteria are very smart. They're smarter than our neutrophils are. It tells the neutrophil to stop in its tracks, don't marginate, explode where you are, and destroy the host tissue. And that's what periodontal disease is. Whereas caries, the host response is constructive. If you have a donut for breakfast, the pH in your mouth, we can measure it, gets down below 5.5, which is the critical pH below which enamel starts to demineralize. But your teeth don't dissolve because there's a compensatory remineralization. Always. The saliva, dentists don't talk enough about saliva. We own saliva, and we should. Saliva, good saliva, the right kind of saliva is the best preventive agent. And the saliva actually mitigates the reduction in pH. And the buffering capacity of that saliva causes remineralization at the surface of the lesion. So microscopically, we're always demineralizing and healing lesions. We just can't see it early enough to detect when we actually have a lesion before it cavitates. This is where it's at. If you take one or two things home, this is one of them. The amount of sugar in your diet is not related to caries. The frequency of sugar in your diet is extremely related to caries. So if you had a half a cup of sugar at each meal, you might have other problems. And you had nothing between meals as far as sugar, and you otherwise took care of your teeth, your caries risk from the sugar would be very low. But if you had just a little bit of sugar in a cup of coffee, or you had a Mountain Dew 1 that you sipped on all day long, your caries risk is extremely high. Because the saliva never has a chance to compensate for that continuous demineralization. It's about the frequency of exposures. Most people don't even understand that. People are willing to change, especially if they know they are at higher risk. We haven't been able to tell people that. But now that we're going to be able to, we can actually look at the exposures and what's beneficial and what's harmful, and look at the net gain or loss at the end of the day. People understand this stuff. They can start to think about it, but they have to understand if they're at risk. So, as I said, I tried to cram a lot into a very short talk. I hope I gave you a sense of the fact that the world of dentistry is changing. This $250 billion business, which is all drill and fill pretty much, is going to change, changing before our eyes. And the sooner we find the devices that will be helpful to detect who's at risk, then we can manage it medicinally before it ever becomes a whole. What's interesting in the US, Listerine is the biggest brand in dentistry. I think everybody knows Listerine. It's been around since 1886 or something like that. Basically hasn't changed. It's thymol, mothballs, and alcohol, essentially. The old ads they had, I hate it, but I use it. But it's good stuff, And for years and years and years, for over 100 years, they talked about reduction in plaque and gingivitis and bad breath. Now Johnson & Johnson bought the company a few years ago. Now they're talking about caries prevention for the first time ever. This is an over $1 billion brand, it's the largest brand in dentistry. So the fact that they're talking about caries, they have a reach to the consumer, way more than dental professionals do. And they're talking about preventing through medicinal therapeutics. But what if I knew I was at higher risk? Then I'm more likely to use not Listerine, perhaps a prescription rinse or varnish or some sort of product that would be developed because I can tell who's at risk and who isn't. So the world of product development in this arena is just emerging right before our eyes. So we're thrilled that the Center for Pediatric Dentistry, which just opened, and I invite anybody to come see it. Our objective is to do that work and to study those kids here and find out why this kid get a lot of cavities, the other one didn't. All these different factors that I've touched on today. And then work with industry. Work with our inventors here at the UW. Develop devices that can detect who's at risk and who isn't. And develop solutions that can be tested here but benefit the kids in Zambia or in Thailand, everywhere, before they get this devastating crisis as their diets change. And they will have that problem. So that's the end of my talk. I think I have time to take a question.